I want to talk first about what this talk isn't. This is not a discussion of how to treat obesity with diet and exercise. There's actually a whole behavioral talk I do. It's also not a talk specifically on how bariatric surgery works and impacts outcomes in detail. It's also not a pharmacology talk on how to treat obesity and prediabetes. Those really are each their own kind of pieces. This is what I would call a process talk. And it's really, I realized when I was writing it, what I've pretty much spent the last 20 years doing. My colleagues in endocrine can explain the details of insulin resistance much better than I can, and my colleagues in GI would be much better at the pathophysiology of fatty liver disease. But what I do is I treat people. So theoretically, you don't have to raise hands, but all of you clearly treat people affected by obesity. And my guess is by now all of you have treated people who've had weight loss surgery. That certainly wasn't the case when I started my residency. I'm guessing most of you have not prescribed medicines for weight loss, or at least not often. When I gave this pharmacology talk to our nurse practitioner colleagues and partners, that was very rare. I think my physician colleagues, based on my experience in weight management, do a little bit more, but it's complicated. So for this disease that affects more than 50% of our patients, most of us don't really treat it. Most of us haven't had huge classes on the pathophysiology of obesity or reviewed the 800-page booklet that is the guidelines of management and overweight and obesity in adults. And I, at least, was not trained to treat obesity. I've trained a lot of people to treat obesity now, and I wasn't trained to counsel people on diet and activity changes to support weight loss. And when we think of all of the diseases these lead to, that's a big foundational piece that's not very well solidified through training in medical school or in postgraduate training. And so most of us feel a little uncomfortable or even unqualified to treat obesity and diabetes, and don't really know the basics of the treatment guidelines and don't know how to, and this is perhaps the process piece that's hardest of all, don't know how and how much to incorporate the treatment of prediabetes and obesity into practice. So on the process, what we're going to do today, I hope, is three reasonably clear things. One is to define what the recommendations are for screening and diagnosing prediabetes and obesity. So how do we screen and how do we diagnose them? If we're diagnosing them, we've got to talk to our patients about them. So I want to talk a little bit about how to talk to patients about the results of the screening, because they can only get better if they can use the information that we understand about them. So we want them to understand the risks from the diagnoses, and we want them to know, especially with things around obesity, what effective treatment options are for obesity and diabetes. And last, we want to really partner with patients to develop and follow plans to reduce their risk for diabetes and other conditions that go along with those to improve their health. So this is really a process trajectory. I'll answer specific questions at the end, but that's really where we're going. So screening for overweight and obesity. Most of you now, again, not in my training at all, now pretty much know what a BMI is, body mass index. We're supposed to be getting body mass indexes on patients annually. What that means is getting a weight annually, and in adults getting a height at least every 2 years, and not a how tall are you, Mrs. Smith, who will never shrink no matter how old she gets, right? For reasons that not only involve BMI, but also Dr. Ballou's specialty, we also want to know about changes in height over time. So we actually want measured heights. Whether or not to get a waist circumference is really a little bit more of a complex question. How many of you have actually gotten a waist circumference in clinic? Got like 3. It's difficult. First of all, you really need landmarks, so you've really got to feel somebody's iliac crest. The belly button is a moving phenomenon. It makes people feel uncomfortable. And interestingly, once the body mass index is more than 35, it's irrelevant because they're high risk anyway. And at the end of the day, unless you're really following it, your eyeballs really tell you. There's some cases where it's added value, but for day-to-day practice, it's really not. If we're going to prioritize something, the BMI does about 85% of what we needed to do. What I did want to point out, though, and this is the thing we don't talk about with obesity, and I want to ask this for diabetes. How many people, when you talk to your patients with diabetes, tell them, even if their hemoglobin A1C is 6.5, that the disease may progress and they still may get complications? You see some attendings, but not a lot of hands. Most patients don't understand that controlled diabetes is a progressive disease. Most people don't understand that you can get complications. Obesity is also a progressive disease, and it, as you know, develops more complications with time. And so when we think about it, you guys are really used to the table on the left, normal weight, overweight, class 1, class 2, class 3 diabetes. But when you look at outcomes, the other piece that goes along with them, and this is the Edmonton staging system, which is very useful, is really the comorbidities that go along with it. And what's nice about this system is they include in medical, functional, and mental comorbidities, because we know, for instance, with depression, the outcomes are much worse. It's just a good mental model. I don't want to kill anybody with it, but when you've got the person in front of you, when we get to these screening results, it's really important to think in terms of obesity and prediabetes and what when you're thinking about treatment. You know, this isn't an infection, so, sorry. So what you can see here is if you just take BMI over time, you know, obviously, and this is over many years, you can see mortality over time, but it's when you separate people by their risk factors that the BMI mortality really shows. So the more comorbidities you have, the decreased survival over time. And so I just really want to make sure people are not just thinking in terms of what's the BMI and how severe is it, but what do they have along with it. Because the goal is to hopefully treat aggressively before they develop those complications and not watch them happen. So the scope of the problem, Dr. Flagel is an epidemiologist with the CDC and who gets to update these numbers. About a third of us nationally struggle with obesity. About 35% men, 40% women, and the combination of obesity and overweight are 69%, so it is more common than gender. The other thing that's important, particularly in women, is that the severity of obesity is increasing. Obesity is a threshold mark at 30, but the number of people with worsening BMIs, again, where the comorbidities track, is worsening as well. That wasn't true for men, but it is still worsening for women. And we worry a lot about obesity prevalence in kids because it's such a high predictor of beginning your adult life as an obese adult. We know that obesity disproportionately affects those who are more vulnerable. So we know the obesity prevalence is 77 to 80% in non-Hispanic Black women, Hispanics and Mexican Americans, overweight and obesity combined, I'm sorry. And it's highest in the lowest socioeconomic levels. So in Cleveland, African American women have an obesity rate over 50%. So most people know a lot of these risks, but we can't, many of them aren't modifiable. But then we go and screen for prediabetes. Now, how many of you are actively screening for prediabetes? I'm seeing this more with folks. A few hands? Okay. So the recommendations are, the main two are the American Diabetes Association and the United States Preventive Services Task Force. And they're a little different. Basically, anybody with a BMI of greater than 25, and then the age at which you should start, regardless of other risk factors, is 40 under the USPSTF and stops at 70. And with the ADA, it's just greater than age 45. The frequency of repeating the test, if the test is negative, is right now modeled at about 3 years, although they're not sure if that's the right level. But once you have an abnormal test and you have a diagnosis of prediabetes, then you're monitoring, you're not screening. Monitoring is yearly. What's a positive screen? Again, it depends on whether you're using the ADA or the World Health Organization. The ADA is 5.7 to 6.4% buys you a diagnosis of prediabetes, and that's more what's used in America. In Europe, they often use the WHO more, which is 6.1 to 6.4%, and that group certainly has a much higher risk of becoming diabetic short term. Those correlate to fasting glucoses in the 100 to 125 or 110 to 125 milligrams per deciliter. So if that's how we diagnose it, a person to prediabetes, what we're worried about in part is a conversion to diabetes, right? And that risk, depending on group and depending on what you look at, is somewhere between 5 and 10% annually. But I think the more sobering statistic is if you have prediabetes, you have about a 70% chance of getting it in your lifetime without intervention. And that's a pretty big deal. The other thing, and this is the thing that I think, and I have a patient with neuropathy too, above her knees, and I'm seeing this more and more, is you can develop macro and microvascular complications typical of diabetes while never being diabetic, while being in that insulin-resistant threshold. And that's being increasingly recognized as well. So again, this is really a spectrum phenomenon as opposed to a threshold phenomenon. So you, depending on people's sensitivities, those things can develop at lower hemoglobin A1Cs. So I think what is very sobering is 1 in 3 Americans has prediabetes estimated, but only about 1 in 10 actually know they have prediabetes. And this really is the big thrust of the CDC's Prevent Diabetes campaign, and I'll give you the website at the end for the toolkit, and we're going to be doing a lot over the next couple of years here to make testing and treatment more part of how we do things because it is so many people. But the risks, the other thing that's really important is when you treat prediabetes, and this is what the CDC toolkit doesn't do, is it doesn't talk about obesity. Well, 85% of the people with prediabetes have a BMI over 25. And in addition to that, for some groups, such as some ethnic groups, the risk for prediabetes and diabetes goes up at a BMI of 23.5 in the higher normal range. So you can't really deal with them separately. And recommendation-wise, it's actually silly to deal with them separately, and I'll go over that in a minute. The other piece is if things go all right, we get a year older every year. And age is also a big predictor of developing prediabetes and diabetes. So over time, this is something that becomes increasingly risk in people's lifetime just by virtue of aging, regardless of the BMI factor. So how are we doing on screening? Again, lots of variation because it's difficult to tell when people do things irregularly and not part of sets that can be tracked real well in the MRs. Some studies show ranges of screening for prediabetes as low as 5% and up to 40%. But it looks like less than 5% of people get what's considered to be the standard of care counseling, but physicians say when they recollect that they refer about 25% of people, but we're not sure what they refer to because as we go over treatment, the most recommended treatment isn't a medicine, it's a behavioral program, and the access to it's tough. So it's tough to know what to make of those results. We know more about obesity screening with electronic medical records, and those, depending on how you assess the height issue, range from 25 to 75% in general in studies on obesity screening. So we talked about what we're diagnosing and how to diagnose it with screening. Now we want to know what to do with the results and the risks of those results and what are recommended treatments before we figure out how to talk to patients. So when you're talking to people about obesity, because that's the thing you get immediately, right? You know their BMI when they walk in the door. Most people aren't real comfortable talking to patients about obesity. It gets a little bit easier with time. There's a real nice advocacy group, the Obesity Action Council. If you ever go to their website and are looking for communication tools, they have a lot of really helpful ways to talk to people about obesity. Not surprisingly, patients do not like the word fat and obese and diet and exercise. Overweight, unhealthy weight, eating and activity habits are words that are preferable. There are also words that don't make them in the wrong, and they're words that can do something about, right? But one of the things that's important is people do want us to talk to them about diabetes. There's been a lot of, or about obesity. There's been a lot of studies about providers and patients, and basically we talk to people about a third of the time about obesity, more so if it's more severe, but the patients uniformly want us to talk to them about it, with one exception. And I hear this all the time in weight management clinic because I have a very selected group of patients, unless we're judgmental and nasty. And that's actually dangerous because then patients avoid coming back. It's why some women in particular, but a lot of patients who struggle with obesity don't get preventive services and other things because no matter what complaint they're in on, they feel like the provider says, yeah, we'll just lose weight. So when we talk respectfully, it's incredibly powerful. When we are dismissive, it can actually be harmful. So when we're sharing the diagnosis of obesity, they do want to hear it, but they want to hear it in ways they can help with. So they want to talk about weight loss to guide recommendations because especially with weight loss, there's a lot of commercial stuff out there, right? The other thing that's important is it works. And I know this has to feel frustrating as a primary care provider, as a specialist. You tell people to lose weight and it feels like there's very modest progress. But if we think of ourselves as physicians as a medication, we have somewhere between a 3 and 6 month half-life. When we talk helpfully and make goals for people about activity change and diet change, you will see improved choices in those areas for somewhere between 3 and 6 months. So it really does help, and what you'll find out is the problem isn't that we're talking to them about it, the problem is actually the intensity of the intervention. The other thing that's important is we need to also get as providers and give trainees as providers what they need as well, because we know, and this is a study I did with actually 3 of the residencies here and 22 of the residency programs throughout the states, that when residents are taught to counsel people about behavior, they do it more often. We found no difference in specialties between knowledge about obesity and its comorbidities. What was very striking, and I thought rather funny, was shockingly, the OBGYNs were the least comfortable talking about people. The family medicine folks were the most comfortable talking to patients about obesity and counseling, and we were pretty close to the OBGYNs. So that was pretty uniform. So it is a skill set, the communication piece with this. If you talk to them about obesity in the office and you get the A1C or are dealing with one from before, you have to talk about the two together. But in most cases, they really need to understand, because otherwise what your plan is won't make sense, that in most cases the obesity is driving the diagnosis. And the management for pre-diabetes is pretty much the management for obesity, except the treatment offered may vary by body mass index. So it's kind of, again, silly to think of these separately. They really are, the overlap is really enormous here. And I want to actually just demonstrate the overlap. So what you have on the left here is all the things we do with a positive BMI versus a negative BMI, or a positive prediabetes test versus a negative prediabetes test. And what you can see is the only difference once somebody's overweight is that instead of referring them to the diabetes prevention program, we refer them to a program that's pretty much the same but is an intensive behavioral weight loss program. That's it. So let me go through what these are. So basically, if somebody has a BMI over 25 and has a positive prediabetes test, we're supposed to share that they have an elevated risk for cardiovascular disease, diabetes, and overall mortality. And we're supposed to do that if they have a negative prediabetes test too. Waist circumference is used with a BMI under 35 and more than 25 to help understand if they have higher or lower risk due to central obesity. We're supposed to initially counsel folks that a weight loss sustained of greater than 5% can reduce risks for all of those things. More is better, but that is medically important. We're supposed to counsel diet changes for weight loss as part of a lifestyle change and give them access to a program that lasts for greater than 6 months with lifelong follow-up. This is why talking to a patient twice a year to 3 times a year isn't effective. The frequency needs to be much higher for most people to make and sustain change. If the person has a positive test for prediabetes, we're supposed to also refer them to the diabetes prevention program, which I'll show you the results on later, but is the most evidence-based program we have for giving them about a 66% reduction in the likelihood of getting diabetes. We're supposed to encourage them to have increased lifestyle. One of the things that's important is you really want them to be doing 30 minutes at least 5 days a week, if not more, because this is for a combination of cardiovascular health but also maintaining a weight loss, which is a higher level of exercise than just for cardiovascular health. The other piece is we need to provide a comprehensive office evaluation to understand what else is going on. Do they have sleep apnea? Are we worried about fatty liver disease? Do they have undiagnosed or undertreated mood disorders? Do they have a weight-bearing arthritis? What are the other things going on? Are we giving them meds that are working against either of these diagnoses? So that's the other piece with this that it's not just the behavior, but we kind of medically have to help them prioritize and understand things so they can align their treatment. And then we need to continue to follow them. If the BMI is greater than 30 but less than 35, we can consider adding weight loss medications to increase weight loss sustainment. We'll talk about that in a little bit. And if the BMI is over 35 and there is sleep apnea, or if it's over 40, regardless, we should strongly consider a bariatric referral. We'll talk about the relation with bariatric surgery and prediabetes in a little bit. So again, these really don't change with the negative prediabetes test, except that they're not eligible from an insurance standpoint to go to a diabetes prevention program. So BMI really drives the whole thing. As I go through these next pieces, remember we were going to diagnose them and then talk about what the evidence-based treatments were for prediabetes. The evidence-based treatments for prediabetes follow exactly the levels they do for the obesity treatment pyramid, which is that lifestyle modification is at the foundation of it all. To that we may add pharmacotherapy, and to that we may add surgery. When we talk about lifestyle therapy, there are 4 components, and they can be done in more and less laborious ways. But if you look at people who keep off weight, they either routinize or actually do all of these things. They adopt a way of eating that consistently is much lower calorie. Usually, if they're not going to be miserable, ends up being a little higher protein, a little lower glycemic index, and lots of vegetables. Fast food and sugar drinks just kind of go away, and people who keep it off. They are regularly physically active. The likelihood of keeping off weight long term is very low because of that reduction in resting energy expenditure you see with sustained weight loss. Without that regular physical activity, it's also harder because of the loss of muscle we have every year, which you can slow down or eliminate with physical activity. They need a weight loss goal. How many people actually tell their patients a weight loss goal? How many people talk to them about a 10% goal? People need a target. Weight loss is kind of slippery. And interestingly, people always talk to me about unrealistic expectations. I think that's shifted a lot. I was with our endocrine fellow, Dr. Iqbal, the other day, and we have 3 patients in a row, and without any prompting, their preferred first weight loss goal was right on the money at a 10% mark, and it was really funny. I'm like, wow, all right. So some messaging is getting through in a little bit healthier of a way. And the last thing is we have to teach them to be monitors. I don't think any of you have a diabetic not keep track of their blood sugars. People who really have unstable blood pressures are pretty routinely recommending home cuffs. People need to watch their weight and really pay attention to it so they can understand it as a fluid system that has influences. So, okay, I just want to define lifestyle treatment. It's basically all the non-drug treatment that we talked about. But the thing that's really interesting and different than smoking is, remember, this is a lot harder than pills. This is a person deciding. All of you, I think, probably, especially for the residents, think your life is going to be different in 5 years, or at least you hope so, right? Counting on it. Otherwise, we'd have to get psych consults. But when you think about all the things that change day to day that affect meal planning and sleep and movement, the idea of engaging in a plan that affects globally how you eat and how you move and persisting in it as your life is continually changing as well is really daunting. It's way harder than not doing something. And so we really need to help people engage in really a plan that they adapt and monitor over time. So it's dietary patterns, it's activity level, it's sleep and quality, but it's doing those around a lot of cycles. So if we do this, how good can it get? I like this slide. This is a researcher named Leigh Peralt who has a really nice chapter in a lot of publications about type 2 diabetes prevention. And the slide here shows you in a lot of international trials that were similar to diabetes prevention program, what kinds of reductions in conversion to diabetes you get. And what you can see, as most of us know from the diabetes prevention program, the reduction was about 58% in the risk of diabetes compared to people who weren't in the program. And you can see the range, depending on the program, was between a low of 29 and a high of 67 in Japan. So the point is intensive behavioral programs are consistently, that include regular walking, are consistently showing a little bit of weight loss. They're usually in the 5 to 10% range, and a dependable reduction in the risk of converting to diabetes. What is interesting in this is a lot of people now are saying that's not good enough, and what we actually need to do is aim for people to get normal glycemic again and out of the pre-diabetic range. So watch for that. I think there's going to be a lot of, right now the okay thing is if you're still pre-diabetic, but there's, I think, going to be an increasing push towards, especially people who are in the higher range, to watching that A1C fall and perhaps normalize. So the DPP is a lifestyle intervention among those with prediabetes. There was observed a 58% reduction in the number of new cases of diabetes overall, and a 71% cases in those most vulnerable to it, the older patients in that group. These results were achieved through reducing calories, but not counting calories, and it was more like the healthy plate approach that we use, It was the healthy plate approach that we use here. Increasing physical activity, which for this case meant walking 30 minutes 5 days a week. A weight loss minimum of about 5%, which means about 10 pounds in a 200-pound person, right? So that's not too crazy to imagine. It was such strong evidence from this that basically this is the recommendation as your first referral for anybody who has prediabetes to do. But let me talk about commitment. How many people have patients who have a hard time making it here for an appointment? We all do, right? The diabetes prevention program is weekly for a year and preferably 2 years, plus the exercise. For those who can do it, it's phenomenal. Now, the payoff's great, and I am not saying that is not the best hour they're going to spend, and it's increasingly covered by insurance. But one of the things we've got to talk about, too, is the people who can't do it, right? So it is the #1 recommendation. It is the thing we should be referring, even if we do everything else or anything else. But a lot of people simply won't be able to do it. I want to actually briefly talk, one of the most powerful programs was Encore, actually, which was done with DASH and had exercise too, which had a 19-pound average weight loss. So diabetes prevention program, there's another one called Look Ahead that's had great results too, but they were different groups of folks. But there's been multiple examples in the States of these. But these were all done, remember, with volunteers, not patients. I'd like to show you some patient results. Most of you know Dr. Riccardi. Many of you know Janine Leon. And are Siobhan and Mary Ellen here? My cohorts in crime. So the STRIDES program is now actually certified provisionally as a diabetes prevention program, and I will let people know when you can do this here. Does anybody have patients in the STRIDES program? Got a few? Yay, okay. I do this at Middleburg and Broadway right now, and we're looking to, actually we just applied for grants to hopefully expand the program. But I want to just show a little bit about what this looks like. So we had a development phase here with some grant funding over the last, since 2006. What was important was when the Weight Loss Surgery Weight Management Center was founded, the program was expanded institutionally and is now 6 times the size that it was then. And over the last 3 years, the format was adapted with a huge amount of effort on Siobhan and Mary Ellen's and mine and Janine Leon's part to make it consistent with the diabetes prevention program. And so we're awaiting final certification, which means we can take Medicaid patients with us. It's a big deal. So it expanded from 15 classes over a 16-week period, because when I started this, 4 months was what was recommended, to 22 classes over a 6-month period that then cycle again because people learn. So that's how it becomes a 12-month program, and now we also have another 12 months of follow-ups. And this is typical of DPP. It's group learning, but we also give individual coaching. The classes are cyclical, which none of the other programs are, and we do this because we find, especially with patients with health disparities, that when somebody's ready, you've got to get them in now. You can't say 5 months later the next program's going to start. This is actually what we did that nobody else had done, was the program's written at a 4th to 6th grade reading level, and it's culturally flexible. And we started the program at Buckeye with basically entirely African-American women who traditionally in programs have had much more modest results. It's now also at Middleburg Heights, and both sites have had packed enrollments since 2015 when we expanded. If you want to talk volume, so in that period of time, there's been over 8,000 visits for about 494 adults. The mean age at both is about 54. It's 90% female. I know you're all shocked that it's women who would show up for a class on diet and exercise and not men, but you have to table your expectations. This is what's actually really important in both of these. The average BMI in these classes is 43. That's absolutely, I'm not going to turn anybody away, but you realize statistically that every one of those patients qualifies for a gastric bypass. And so behavior is a rock-solid part of all this, but this was a really humbling thing when we started this program, and it was true when it was a smaller program too. The urban site's 85% African-American, Middleburg's 85% Caucasian, but the average BMI didn't differ. It's a little older in the Middleburg site. We've got a few more retirees out there, but otherwise they're pretty similar. What was interesting too was dropout rates. Not shockingly, there was a little more dropout in the urban site than in the suburban site. But what was interesting was the weight loss over time really tracked about how we should. And these are not volunteers. These are just patients. I am not incentivizing them like the DPP did. I'm not paying them to come. I'm not transporting them because we can't even get patient transportation. They're just coming. So basically, at 45 days, they're at about 2.5% on average weight loss, 90 days about 90%, and at 180 days, we are hitting the 6.5% weight loss mark on average, which means some people have a lot more. So it is hitting what should be there for diabetes prevention. Now, some of these folks actually have diabetes because we actually include everybody, but we have a subset who are the formal pre-diabetic folks in it. So anyway, that's just to let you know in real terms, it's not like other people will go to the program. We know our patients will go to the program, and that if they go, they'll benefit. Okay, so that's what we presented earlier. That's enough, but I wanted to let you know what we're doing locally. So weight loss success is a lot. It's keeping track, especially initially. It's learning. It's changing. And so if you're going to do something, it's got to be, this is how we get to how we talk about things with patients, it's got to be consistent with somebody's values and priorities because, you know, most of these people may have a sick mother or a job or maybe going back to school or whatever. This has to resonate with them. So when we talk about the weight loss with behavior, we now want to see what would happen with meds. Now, what most people are more familiar with is the metformin on the left, which people knew from DPP that you reduced your risk of becoming diabetic compared to usual care if you took 500 metformin a day by about 30%. And you can see it was actually more with rosiglitazone. No, it was troglitazone in DPP, sorry. It was a 75% reduction, but of course their weight all went up. And you can see even with basal insulin, glargine, there's a 20% reduction. And with the carbos even, there's a 25% reduction. So we know that diabetes meds given can prevent conversion to diabetes, but the difficulty is if they're not impacting the weight, other things are marching on, right? The knee arthritis isn't going to get better. If you look at, and this is a smaller group, but other meds will do this too, if you look at meds for obesity, so you treat the obesity with obesity meds as opposed to treating the prediabetes with diabetes meds, how does your risk for developing diabetes change? And what you can see is even orlistat, which getting people to take that's a whole other party, but even orlistat was more potent than metformin in reducing your risk of getting diabetes, and liraglutide, which is Victoza, was more potent than any of the other ones. So one of the things here that's really important is if you're going to do lifestyle, and you need to do lifestyle, the meds don't really work without it, again, treating the obesity does treat the prediabetes. It does reduce the risk of conversion to diabetes, and it hopefully can, in many cases, return people to normal glycemia. So the thing about giving medications is they have to be given according to guidelines, and when you're addressing obesity, this is what's hard in practice. This is why I'm letting you know about the STRIDES program and Weight Watchers if they're here at work. Medications for obesity really don't work unless the patient's working it. And so that you get much better results and much more sustainable results, but it's really a both and. And so in practice, that can be tough. So this is one of the reasons we'll talk about weight management. You guys have obviously the resource of our clinic here that most people don't. But the frequency with which you're supposed to be monitoring somebody you're putting on meds for diabetes is at least monthly. And that's with other behavioral stuff. And most people don't have the luxury of doing that, clinically speaking. We're actually hoping to provide with some practice changes, some options for the primary care practices to have some help with that over time. I certainly want to see all the weight management folks we can, but it's probably more important that I'm seeing the folks with the BMIs over 35 than the 25 to 35s. So we need systems that do that. But when you're talking to patients about the meds have to be, even if you're not doing it, they have to have a plan to do the behaviors as well. And the other piece is you're not treating an infection. Every patient I have says, so when do I stop it? If you were giving them hydrochlorothiazide for their blood pressure, most of you would say, you might be able to get off it for a while, but it is likely that you will need it lifelong. If you want the lifelong reduction in the conversion to diabetes, you want the weight loss you have to be sustained, the treatment that leads to those improvements is the treatment that sustains those improvements, both behaviorally and pharmaceutically. So it's really helpful to help patients get that verbiage when they're used to snake oil for 12 weeks at the store or Adipex or other things like that. So it's really a change of a conversation. And bariatric surgery for prediabetes. Now this is really, you know, I've watched this juggernaut for the last 20 years. The evidence of bariatric surgery for diabetes prevention is extrapolated from studies, and that none of the studies were done with the primary endpoint of having prediabetes reduction to diabetes. But bariatric surgery gives you a 15 to 50% weight loss as opposed to 5 to 10, which is what we can expect from behavior. As I mentioned, there aren't any randomized trials specifically to test this hypothesis, but what's been observed in the larger bariatric trials is that gastric bypass and lap banding even had a 30-fold reduction in the risk of diabetes onset post-surgically. Sleeve gastrectomy is looking similar, it's just more recent. The number needed to treat in the Swedish obesity study to prevent a case of diabetes was 1.3 people over 10 years. That's pretty potent. And recent meta-analysis compared multiple intervention strategies for diabetes prevention, highlighting the 84% risk reduction with bariatric surgery, sustained. So back to my original premise, if you have somebody with a positive prediabetes test in front of you, it matters hugely whether their BMI is 25 or 45. You can't have the conversation separately. One is always in context of the other. I just want to remind people when they're having the talks, surgical outcomes, you lose most of your weight in 12 to 24 months. The average BMI reduction is about 16 or so in 12 months with RYGB and about 13 at 24 months, probably because of some villus hypertrophy and decrease in dumping syndrome. No, we don't do vertical banded gastroplasties anymore. But the other piece that's important is, most people lose between 25 and 35% of their weight long term. And if they do longer limb bypasses, it's more so in folks who are really obese. So, this is a really durable result. The other piece is, kind of how people do it. And I'm sure everybody's seen cases of regain, but I have never seen a case of significant regain where people are actually following directions, ever. The mean excess weight loss, when they say 61%, that means about a 30% weight loss over time. It was average for about 22,000 cases. At 10 years, that's probably about 50% weight loss or so. At 20 years, which I think is impressive, you had a mean weight loss of 26% with the Swedish obesity study. And that's a pretty long-term piece, too. And again, that's not taking a medicine for all those years. The other piece, too, because it's a higher risk population, was in many populations, but in veterans even, there was a really good reduction in mortality with bariatric surgery. And you're treating prediabetes, but the thing about bariatric surgery is you're also treating hypertension, hyperlipidemia, sleep apnea, GERD, fertility, depression, right? That's the other piece of this. I've really just pretty much that uncle for people who really are willing to take this on. Because what other operation treats more than the thing it's treating? Knee replacements fix knees, right? Stents fix clogged arteries. Gastric bypasses fix depression, sleep apnea, diabetes, hypertension, dyslipidemia, LVH, pregnancy. It's really humbling. They need all the supports around them to make it work, just like you can't pick up, Camels and Big Macs after a heart surgery and think it's going to all work out. But it's really, really quite impressive. So the first thing we're going to do is talk about how we screen and diagnose prediabetes and obesity and really lay the case that this is one conversation with patients. It's just contextualized. The second thing is we want to make sure you can talk to patients about the roles of diabetes prevention program, which is the recommendation on the CDC site, but also because they're going to ask how meds fit into this treatment, how surgery fits into this treatment. The last thing, and this is the thing that I think is the funnest part, it's why I do what I do, is we get to partner with patients to develop and follow a plan to reduce their risk of diabetes and other conditions and improve health. And the reason this to me is fun is this fully reflects the patient's priorities. The plan is owned by the patient with our support. They are flying the plane. And it has to do with their readiness, which, as we all know with life events, can change by the minute. It has to do with their preferences, their resources, and their life context. So this is, to me, where the fun of this gets going. If you're not, basically, as long as you're nice, you focus on them and you ask questions and don't kill yourself with charts, it'll all work out. There's not been a counseling tool that's been proven way superior to any of the others. I know some people here do motivational interviewing. I know some people do 5As. I've been involved in a lot of the validations for teachable moments, and we've also used a tool here called the PACE program, which is a stage of change for readiness to change eating and readiness to change activity, because you actually have to do readiness by activity. But they're all fine as long as you're kind of systematic and kind of keep going back. But there's some things we want to really partner with people and say it explicitly. One is the why bother thing. People really think, is it a big deal to lose weight and keep it off? I can't tell you how many patients have said to me, even in the last 5 years, you know, I'm keeping off about 15 pounds. And it's clear, if you look on synopsis, they've been keeping it off. And every time I go in, my doctor says, you haven't done anything. You just lost 15 pounds and you haven't done any more. And I just want to beat myself. You know, it's, again, getting and sustaining weight loss and then making sure we're not working against them. So one of the pieces is to really understand that a BMI is a snapshot in a movie. And I really like that synopsis tool, because if you click under the high blood pressure piece, you can go back 20 years and look at the weight curves over time and see what happened when they were put on steroids with their asthma, what happened when they got their knee replacement, what happened when they were put on the Depakote, what happened when they got off the insulin and got on the Victoza, all that stuff. So it's really nice because you can help them understand where they're going. And you want them to know that this actually improves outcomes. The other pieces is how this works together. People want to pick between diet and exercise. Again, we're not going over which, but one of the important conversational partnering pieces to have is really the diet is what drives the weight loss on the scale. I know you guys know that, but patients really don't. They'll think I'm walking 5 times a week. It's not self-evident. So really explicitly saying as they're making a plan, I get that you want to start with just exercise, but you know you probably won't move the scale yet, just so you can set expectations. Or if they start on the diet changes and can't keep it off, those are pieces. The other thing is, how many times have you heard a woman somewhere in the 48 to 55 range say, I'm doing everything the same, but I've gained 10 pounds? Right, as they hit menopause, you know, we know that with the loss of estrogen, it's more difficult to hold on to your muscle, your resting metabolic rate slows down. You know, those pieces are just physiologic changes, right? Some women have a predilection for weight gain with pregnancy and hyperplasia of their fat cells. Other folks really change jobs. I've had people gain a lot of weight when they go from floor nurse to contact center nurse. So really helping people and partnering with them and understanding the weight that's how the weight relates to all parts of their life is really important, their life stage and their activities. The other partner piece is it can't be for one appointment. People are going to hit setbacks. I can't tell you how many times patients say to me, you're going to yell at me, Dr. Seeholzer. I'm like, I don't yell at anybody except my kids. It's really important to help them know how hard this is and that it is a game of persistence and redesign, and persistence and redesign. Because that's really what's been shown to help people sustain results. I have people now who've lost and kept off weight for 20 years, some of it straight behaviorally. And it's really this identify, adapt kind of piece over time. This is kind of skills in the way of managing their expectations or ours. The other piece that's important is even doing everything the same. Remember, some people have a harder time with weight loss. We'll go over that. They're just more resistant to it with the same maneuvers. So we need to let them know it's lifelong, but that we don't know just because their neighbor had a good result with this, they may not have as good a result. They've got to have individualized results. So we already mentioned the pyramid here with the pharmacotherapy in the middle and the surgery at the top. And the 4 things that you have to do: you have to pay attention, you have to move, you have to eat better. And really, goal setting we know is linked with increased success. And we've got to talk about medications and surgery. One of the things is patients can sense a mile away when we avoid talking to people about obesity treatment and medications, and it delays them in getting effective treatment. And a lot of times we do it just because we feel like we don't know what we want to do or how good it's going to be or what bad things we could do. But we've really got to have the conversation. We need to advocate and facilitate and connect them. Our job isn't to solve it. Just like, you know, if I have a cellulitis isn't, you know, improving, I'm going to send him to Dr. Hecker. She's going to fix everything. It's going to be better. Dr. Weiss just fixed one of my patients recently. It's having friends that we connect them with that matters here. It's our responsibility, but we don't have to have all the solutions. And the same with surgery. We really need to let people know they're not failed. They may not say it, but I still all the time hear patients say that surgery is the easy way out, or I failed because I can't get this myself. And I really actually talk to them about their resting metabolism and how that's not under their conscious control. And actually, our hunger isn't under our conscious control, and our satiety isn't under our conscious control, and our sleep quality is not under our conscious control. So we have this awareness of it, and we take a responsibility, but we're actually not in control of a lot of the factors that really govern our weight. So really helping people understand that weight loss surgery saves lives and improves health overall, that the role of medications and surgery are not instead of lifestyle, they are tools to help people get better results that they couldn't do without it, and just really making sure, and I'm really aiming this at the residents, that we don't want to avoid talking about these things any more than we would avoid talking about the treatment of diabetes, arthritis, or hypertension. I want to say a word about readiness before I close, and this always cracks me up a little bit because the second one, the stress level, I haven't yet met a patient who is free of all life crises at the clinic. But the idea that readiness for change and basically the level of change isn't just, am I ready? Yes. It's what's going on in your life, what other medical issues are going on, what time do you have, so the plan needs to reflect that, and how am I managing it? The one thing is I really wish they wouldn't use the word motivated, and that was the reason I put this slide up. How many of you residents, particularly, are delighted to come to work every morning? Delighted. Yet my guess is you're pretty committed to being physicians, right? I find it fascinating that people think they need to be motivated to exercise. I don't like people who are motivated to exercise. They creep me out. I can exercise with a bad attitude, and I will get every bit as good of reward from it, and I often do. So, you know, one of the pieces is you want people to not feel guilty for things that have nothing to do with guilt, right? What matters is showing up. I tease, but actually a lot of people will say, well, I'm not motivated to exercise. And I'm like, and you take care of your kids when you're not motivated, you show up for work. It's about doing it. And it really helps people to get out of this. And so that was the reason I brought that slide up, because I think it's an important piece. And then the last piece is getting out of the patient's way. Do they have sleep apnea, and is that what's going on? Do they have undertreated depression? Are they in pain that we need to manage better? What's going on? Are we giving them meds that are working against them? Can we reduce any of them or swap them out? That's a really big part of this over time. I've seen people gain a lot of weight on things you might not think of, but it happens. And this is the last part, is the individual treatment responses. People with more challenges don't lose weight as well. A lot of times because of some metabolic things, you may see a little less weight loss with behavioral stuff, with Black women in particular, who may actually have a more brisk reduction in their resting energy expenditure. But there's a lot of things that can be managed. You can lower fast food intake, things like that. Oh, sorry, keep hitting that one. So generally speaking, the healthy plate approach is what DPP uses. It's a good place to start. We have them around the clinics. This is where, with prediabetes and obesity, you want friends. At our clinic here, along with myself and Dr. Riccardi and Dr. Magliola and Dr. Barry, we also have my partner, Anastasia Driscoll, who's sitting right up front and is feeling better, I hope, as well as Pat Franta and Jackie Icaboni, and we hopefully are going to be having more join us, actually. We have nutritionists who can help if they can't do diabetes. We have behaviorists who can help with eating disorder. If they can't get to strides, the YMCA has a diabetes prevention program. There's Weight Watchers. The point is to find out adult supports. Keep pressing that button. And lastly, we obviously have the bariatric program here as well, so people can contact me if they need to know about that. And last but not least, if you have prediabetes, you can go to this Prevent Diabetes stat for the provider toolkit about how to test and how to share results and what role DPP is. So I'm going to stop there, and am I allowed to take questions? And take questions if you have any. Thank you.